This panel is about blood pressure, and it would be nice if we have questions and comments, if we just could follow the program, and that way we don't get off topic. And so we should be able to cover most of what we have listed as our goals for the day. So my first question is, when you see a patient in your office, do you routinely check blood pressure in both arms? And if so, why? Dr. Parker.
Yes, I check it both arms. Basically, you also want to know if you've got any vascular problems, and it kind of gives you an average. And I also wait. If the blood pressure is high, then I wait 5-10 minutes and recheck it.
Okay. Dr. Hickey?
I learned that lesson a long time ago. A patient kept passing out and having TIAs, and he was going to another physician, and his blood pressure was 110/70, and he kept putting out his left arm. When I checked it in the right arm, it was 230/140, and he had a vascular blockage in the left arm. So from then on, I've decided to take it.
Yeah, it's when they tell you, take my left arm, it's always better.
Right.
Then you worry. Dr. Ashraf?
Yes, I think this is very important because there could be blockage on the one of the arm, especially if somebody has peripheral vascular disease, hyperlipidemia, if he already has coronary artery disease, so there will be blockage somewhere else that could be in the next arm. So we should check it in both arms to make sure that the blood pressure is normal.
So in your patients that have borderline hypertension, do you ever use a 24-hour blood pressure monitor?
Yes.
And do you find it a useful tool?
Absolutely. And I train them to check it at home and to monitor at home. It's always a better indication if they take their own pressure, but 24-hour blood pressure monitor is really very helpful.
You do 24-hour blood pressure monitors?
Yeah, actually, I encourage the patient to check it frequently, especially when they feel it could be high, because everybody doesn't have access to that, and so they could check at different times.
So if they go to the pharmacy and they have their blood pressure checked, what do you advise them to do prior to putting their arms in the machine or their wrists in the machine?
They should wait 5 to 10 minutes, relax, and then check the blood pressure.
You do the same?
Yes, absolutely.
Dr. Lambert?
Same.
Yeah.
Ditto. But I also tell them, a lot of them have jackets on and they just put their arm in. Is to take the jacket off, and if there's a cloth, keep it thin. If not, that's going to impede the blood pressure.
So we know that reduction in cholesterol does not change stroke incidence, but we do know that lowering blood pressure is probably the most important, therapeutic intervention that we have in order to prevent strokes. Obviously, we are concentrated on natural approaches to health. And my question is, what nutrients do you find are the most effective in controlling blood pressure without or with minimal side effects? I'll start with Dr. Lambert.
Usually, when I do that, I usually have a full workup. And the workup includes everything, a full hormone panel, everything from pregnenolone all the way to estrogen in men and women. Then the risk factors like homocysteine, HSCRP, and fibrinogen, so I know what that is. And once I get all that workup done, including I tend to genetics to know what the methylation is, then I go by how to treat that person. First, obviously, is making sure they're multivitamin, they've got CQ10, they've got lipoic acid. But then for the hypertension per se, it's the magnesium. I make sure the magnesium level is good. I actually do intracellular red blood cell magnesium, which lab coat everybody's at these days. So I get that done, and with selenium, I check also selenium. Then from there, I also look at the sodium-potassium ratio, and I get that. So I go to the most basic, and then CQ10 level, I check the CQ10 level, and I get it down, get the CQ level over 2.5 if they have hypertension. And then I use the things.
More than 2.5?
CQ10, coenzyme CQ10. I get, normal is up to, up to 2.5. I usually get it about 2.5 if they have hypertension, cardiovascular disease. And I find that drops the blood pressure. Other than that, the nutraceuticals is hawthorn berry and magnesium together. And the ratio is hawthorn berry, if magnesium is 1 gram, hawthorn berry is 2. It's 1 to 2. And that seems to work. That's using nutraceutical
Yes.
per se. I also use pomegranate with that, which I've started using recently, because a lot of studies showing it actually helps oxidize lipoprotein, and it also suppresses the genomic expression of what causes WBC to go into foam cells, which in turn causes all the problem. That's not nutraceutical, but I still do use ACE inhibitor depending upon the kidney function at lower doses, but I use it only temporarily until I can get them into more nutraceuticals.
And do you stay away from diuretics? And which one do you use?
I tend to stay completely away from diuretics, and if I have to use it, I use something like spironolactone.
Okay, thank you. Dr. Hickey?
Yeah, I agree with the above. I always add an aldosterone-renin ratio. I'm finding a lot of patients come to me on meds and they still have hypertension. And the aldosterone-renin ratio, if that ratio is above 15, I know there'll be a significant improvement if I put them on spironolactone. Magnesium is one of my favorite supplements. L-arginine also, up to 3,000 milligrams daily, is another one of my favorites. I'll go back to my theme. If the artery's inflamed and there's inflammatory markers being released, you have to address that issue. So I'm always concerned at the bottom line with lead because of its inactivation of nitric oxide. So when I don't get a response from L-arginine, when L-arginine doesn't increase nitric oxide levels, I know that conversion is being inhibited, and it's usually by lead or cadmium.
And does anyone, do you use any resveratrol in your management of the hypertensive
No, I haven't.
patient? No. Dr. Ashraf, what's your protocol?
I agree all of the one they mentioned, my colleagues, but I have felt that we need to control the blood pressure instead of giving multiple stuff and going through all the difficult ways. Blood pressure is product of increased heart rate, peripheral vascular resistance associated with other multiple medical problems. So I came up with a combination of dietary supplements which includes Revulfia, Sandal, cardamom, borage, pomegranate, cumin, and coriander. And the combination this does what it does. It comes in the form of like this. It comes like this as a BP net relief. And the combination causes control of blood pressure by reducing heart rate, dilating the blood vessels, relieving the anxiety, and increasing the diuresis, and improving the gastrointestinal function, because all of the above can cause high blood pressure. And combination of these different stuff, including cinnamon, rose petals, cumin, and they all have a positive effect on the control of blood pressure. And if there are any associated side effects related with the Revulfia, they don't happen. And it doesn't interact with any prescription medicine. It can be given with any prescription medicine, starting with 1 capsule twice a day, and dose can be increased up to 2 capsules twice a day, because these are 10 ingredients, and the amount which everybody gets is very small amount. So it doesn't have any side effects, and it has very positive effects of controlling the blood pressure, and that really relieves the burden of the heart.
So what would be the average blood pressure reduction that you see, either systolic or diastolic, with that formula?
It's around 120, and it's like if somebody's blood pressure was 200 over 110, that comes down to 120, 130 over 75 to 80 diastolic. Wow. It's quite effective, and I have found that the effect of this one combination of supplement is better than 2 to 3 prescription drugs.
And do you ever use any prescription medications?
Right. If somebody's what happens actually, the protocol is if somebody comes with blood pressure, first time diagnosed, whose blood pressure is in the range of 150 to 170 over up to 90, I would start as this supplement as 1 capsule twice a day, and watch the blood pressure over 1 week. Most of the time, in a couple of weeks, it comes down and becomes normal. And if a patient comes with very high blood pressure, then we will start with this one, but I recommend to add another prescription medicine, so we as a sort of urgency, so it comes down.
So which medication do you use? Do you use
We could go with
or?
lisinopril, 10 to 20 milligram. The maximum dose we could go to 40 milligram, but because as compared to other drugs, obviously we know the renal function before we give it. We don't want to give it to somebody with creatinine of 3 or 4. So lisinopril I have seen is quite effective.
So in your experience, do you ever encounter secondary reasons for hypertension that we have missed, like in renal artery stenosis or any pheochromocytoma or any other rare conditions? Do you suspect it in your patients? Do you look for it?
Yeah, rarely have I found I've found one pheochromocytoma in 30 years, but I absolutely screen for them if it's a resistant hypertension. And I think if it comes down normally with lifestyle changes, with what I ask the patient to do, and or a medication, if there's no aldosterone renin abnormalities, and I need to put them on a medication if all else fails, and it's number one, depending on how ferocious the pressure is, that would tend to make me screen for renal artery stenosis. We can do that kind of non-invasively now with Doppler, and urinary collections. I don't think I've ever seen a positive pheochromocytoma.
Metanephrines,
Yeah.
And do you customarily look for evidence of left ventricular hypertrophy or
Yes.
diastolic dysfunction that
Yes.
sometimes can be silent?
Routinely.
How do you? So let's say that your patient comes in, sees you, and you identify hypertension. Besides the biochemical workup that Dr. Parker expanded on, do you do routinely an echocardiogram?
EKG first,
Okay.
examination, check the point of maximal impulse on examination, and then echocardiogram. There's no question echocardiograms lent a lot.
And how often do you find any evidence of, let's say, diastolic dysfunction?
Very frequently, more times than not.
More times than not. Because I find that it's very hard to manage those individuals. Do you have any magic formula to?
Chelation.
You do any chelation?
Yes.
In those patients?
Yes, I do. And I do the echocardiogram. I think it's very important to know. We really need to get the root cause of what's causing the hypertension. We talk about generally, but if you've got left ventricular hypertrophy, you need to treat that aggressively, or if they have peripheral vascular disease and viscosity. So even though we're talking in general terms, I think as integrative physicians, we have to zoom in on what is the core point and then treat it. Some patients just get better with testosterone. Mm-hmm. So it's kind of interesting.
So one of the things that I haven't heard is the role of thyroid. Because sometimes patients are hypothyroid, they can be hypertensive too. Do you see that as?
Not frequently.
No frequently.
That's absolutely routine first visit, something I include. What fascinates me is all the idiopathic cardiomyopathies and left ventricular hypertrophies. Idiopathic's a great word. The doctor's an idiot and the patient's pathetic because nobody knows what's going on. It's amazing to me how many of those respond to removing heavy metals from the artery and from the myocardium. It's just incredible to me. I've had documented improvements in voltage and in echocardiographic findings.
Do you do any chelation, Dr.
No,
Ash?
I don't do chelation, but regarding blood pressure, I have felt something very important is obstructive sleep apnea. Mm-hmm. Obstructive sleep apnea is quite a significant cause of hypertension in obese people. So we should take the history. If somebody has snoring, check the weight, about the body mass index, where does he fall. If somebody is obese and his blood pressure is not being controlled, whatever is available, we should pay attention towards obstructive sleep apnea. And everybody should do effort to reduce weight at least 10 to 20 pounds. And regular walking, exercise, they are quite significant in reducing blood pressure. And other thing is taking coffee. Coffee also plays a significant role in increasing blood pressure, so we should pay attention towards that. I have noticed that when I told a patient to stop coffee, their blood pressure significantly drops.
Thank you. You have something
I just want to
add?
make a point. I think sleep apnea is a big missed system. I had sleep apnea. I didn't realize it. What it is it doesn't have to be obese anymore.
No.
They can be very thin, but because we have so many dental problems and development, I think Richard Price, Weston Price, made a big point of it in all his lectures. So if the jaws are not properly aligned, TMJ, they in turn can mechanically cause collapse. So, and that in turn is going to affect the renin-angiotensin system. And they have really very resistant hypertension. And just by using something like spironolactone, you can get a very fast relief. But you have to fix the major problem, which is airway. And don't always have to go with CPAP. The dentists have really gotten very good at using certain appliances, which actually kind of shifts your jaw forward, and you can breathe better. So the old idea of being obese for sleep apnea is, I think, is part of the old generation and old paradigm. In this today, I think we need to check everybody. If they're not sleeping well, if they're snoring, it doesn't matter what the size is.
But also, to one of the simple tests is when you look at the oropharynx, if you are not able to see quite well the posterior pharynx, then you may suspect it, depending on the size, because then that would be developmental. But I have a brief anecdote. I had a patient who was the assistant to a dentist in Calgary, and she had very resistant hypertension. And she came to see me, and I was convinced that she had, she was loaded with mercury, and that was the reason of her hypertension, until I looked at her airways, and she wasn't obese, but she had a very difficult airway that could have been difficult to intubate. So she was on triple medication, and I said to her, you should go and have a sleep study. She had no time to do it. She came, she chelated. Her blood pressure didn't improve. She did have mercury, and I did mercury chelation, and then I chelated her for lead. And finally, I was just ashamed to write triple prescription medication for antihypertensive. And I said to her, you have to go for your test, otherwise I won't see you. She went. Within the next morning, I had a phone call. She was hypoxemic 25% of her sleep. And so she went to use the CPAP machine. And a week later, she was calling me because she was feeling tired, and she had postural hypotension. We were able to decrease her medication by 75%. And so that is, as you said, is a silent problem that we all have, especially in patients that have cardiac arrhythmias or difficult hypertension, then sleep apnea.
You also see a lot of the teenagers snoring, especially boys, and they ignore the young kids. But they already have that, and they may not have hypertension, but they're going to develop it in time. And if you're looking at primary prevention or secondary prevention, that's where we really need to focus on.
Yeah, thank you. So the topic of hypertension, we had like 3 questions, and I added a few more just because of the sake of knowledge. But I would like to see if the audience can give us their comments, their experience, or questions. Dr. Chappell.
Yes, Terry Chappell. And I'd just like to add to what Dr. Asheroff said. I've been using that product for blood pressure natural relief for over a year now.
This one.
It really works. It's by far the most potent nutraceutical for blood pressure that I've run across, and patients love it. Very few side effects. A lot of people come to me for the purpose of getting off medication, and that's one of the classics.
Where do you get it, Dr. Asher?
Actually, there is a company called Natural Relief, which is it's made in USA, and it's available. You can order on the website, or there is an order form. You can fax that. You can have these two.
What's the exact name of this product?
It's called VP Nat Relief.